Hi everyone, myself Dr. Vinoth. Today we will discuss one of the least bothered topic in orthopedics, that is orthosis and prosthesis or prosthetics. Why I am calling it as a least bothered topic? Because many of us come across this topic only just before the commencement of our clinical or practical viva, or just to pass our ASCII, we will be superficially going through these topics, but they have a highly clinical impact, because nowadays most of the patients, whenever they have some problem, they will go directly to Google and they will be searching what are the treatment options. So whenever the patient is having an ankle twisting injury, so they will be immediately searching in Google and they will be buying an ankle supporting brace. So they won't apply themselves directly, they will come to you whenever you are sitting as a medical officer. They will ask you a doubt, sir, whether this ankle brace is fine or whether I should go for a casting. So which method is beneficial for me? So this much of doubts they will be asking you. So only when you know everything, so which type of injury you should apply a cast or which type of injury we should do the brace. So everything you should decide that time. So for that you should know everything in detail about this orthosis as well as the prosthetics. Yes. So what is mean by orthosis? Orthosis are nothing but an external medical device that is applied on the limb or a joint surface to control or to counteract or to compensate a deforming force acting at the limb or the joint surface. Assume that a patient is coming with the complaints of pain and swelling around the knee joint. The cause might be an inflammatory cause or it might be a traumatic cause. So just we want to first assume this thing, emergency measure, we have to give immobilization. So that time we should give a brace that should be counteracting the deforming force that is acting at the joint, and that is the main cause for the pain. Yes. So what are the purpose or what are the types of the orthosis? There are three types of the orthosis. First one is called as the static orthosis, which means this brace is applied at the joint or the limb surface that doesn't allow any movement. Okay. So then the second one, dynamic, this will allow the movement required at the joint surface. Then the third one, hybrid, it will allow one type of movement and it will be not allowing the opposite movement. So that's why it is called as a hybrid brace. Yes. Then what are the functions of the orthosis? So there are four functions. Yes. The first thing is a corrective orthosis. So what is meant by corrective orthosis? Assume that a 6-year-old kid is having the genu varum deformity of the knee joint. Yes. So genu means it pertaining to the knee joint. Varum deformity, the knees are the very far behind. Yes. Though intercondylar distance are increased. So that is called as a genu varum deformity. So we will be applying a brace to correct this deformity. So that's why the one of the function of the orthosis is to correct the deformity. Then second thing is the functional bracing. So what is the function? So the function is the union of the fracture. Assume that I have a patient now with the fracture of the shaft of tibia and the patient has either a nail in situ or a plate in situ, or just the patient was treated with a conservative management. Now what I will do, I will be giving a PTB caliber, patellar tendon bearing caliber, or a functional brace. Yes. Then I will ask the patient to walk. Okay. So while the patient is walking with the nail in situ, there will be some micro motion when I do a dynamization. Yes. So this will allow what function? Non-union to union at the fracture site. So this brace is applied to provide a function which is the union. So that's why it is called as a functional brace. Yes. Then the third one is a protective brace. Yes. So assume that a patient is 45 to 50 years with a early arthritis changes. Yes. Now the patient says that, sir, I don't want any operative intervention. So just to make sure that I will have relief of pain, give some management. So that time we will give analgesics as well as we will give supportive brace. Yes, as a protective brace. Yes. So this protective brace will further, or it will reduce the further progression of the arthritis. Yes. So this is to protect the already degenerating cartilage. So that's why this purpose is called as a protective orthosis. Yes. Then the fourth function, supportive orthosis. Assume that a patient is having an ACL injury or any ligament injury. So the person has to walk. So that time I will be giving a long knee brace. Yes. So with the long knee brace, the person, what will be the complaint of the patient with a ligament injury? They will be having an instability of the knee joint or the particular joint where the ligament is injured. So I will be giving a brace to support that instability. Whenever the injury is minimum, this supporting brace will help, and in that meantime, that ligament, whatever the injured ligament, that will go for regeneration or it will go for healing. Yes. So this time period I will be giving a brace to support the ligament injury. Now we will briefly discuss some of the commonly used orthoses with more importance towards their function as well as indications. First one, hinged elbow brace, because it contains hinges and they are applied at the elbow joint surface. Yes. So why this hinged elbow brace is given? Generally they are given for the varus instability at the elbow joint. Assume that a patient is having a medial collateral ligament or ulnar collateral ligament injury. So I want to give the stability, because the patients with medial collateral ligament injury or ulnar collateral ligament injury, they are more prone for varus instability because their elbow joint is unstable whenever the varus force is acting on them. Okay, whenever a varus force is acting on them, so that time their elbow joint is unstable. So that time, to counteract that deforming force, we will be giving a hinged elbow brace. One more purpose, whenever I am operating any bony fractures at the distal part of the humerus or as the proximal part of the ulna, so that time for supportive treatment. Okay, so after postoperative period, even though plate is in situ, I want to give some extra protection to the elbow joint. Okay, so that time I can give hinged elbow brace. So what is the purpose? See, that I want to restrict the flexion degree. Assume that patient is having pain free in extension, but he is having pain only after 100 degree of flexion. So I will set the hinges at 100 degree so that patient can do mobilization from complete extension to 100 degree without pain. So after that, even when the patient tries to do flexion, it won't be possible because the hinges will be restricting the further mobilization of the elbow joint. So coming to the second brace, it is called as static cock-up splint. Okay, so what is the purpose of the cock-up splint? As we have already dealt about the peripheral nerve injury, cock-up splint are generally given for the wrist drop patients who are affected by the radial nerve palsy. Yes. So most common clinical feature of patients with radial nerve palsy, wrist drop as well as finger drop and thumb drop. So to maintain the wrist as well as the fingers in complete extension or nearly in a neutral position like this, so we will be applying this cock-up splint. Okay, so here we are counteracting the deforming force to keep the fingers as well as wrist in complete extension. So by doing this, what we are doing, we are preventing the tendon degeneration. Okay, yes. So what is the term called as static? Because once this splint is applied, this won't allow any movement at the interphalangeal joint, okay, or at the wrist joint. Okay, so that's why it is called as a static cock-up splint. So what are the other indications? So the cock-up splint can also be used when there is a wrist arthritis. Yes, whenever a patient is having severe pain due to wrist arthritis, to give pain relief and to immobilize the wrist joints, we can give static cock-up splint. Then whenever we do reconstruction work of the extensor tendons, then we have to immobilize the joint with a cock-up splint for a supportive use. Yes. Then other use, whenever there is a tendinitis or tenosynovitis. Tendinitis is the inflammation of the tendon. Yes. On the other hand, tenosynovitis means inflammation of the tendon sheath. Okay. So tenosynovitis of the extensor tendons. Then also we can use this static cock-up splint. So coming to the next one, it is called as dynamic cock-up splint. So it also has the same indication. So what is the difference? See, so here, as you can see here there will be multiple rubber bands will be coming. Okay, 4 rubber bands for the 4 fingers and 1 for the thumb. So okay, so this this thing rubber band holes, yeah, or the glove holes, they will be taking up the fingers. So what is the purpose? See, with this patient can do flexion of the fingers, yes, because in radial nerve palsy only the extensors are affected, yes, the long extensors of the fingers are affected. The flexors which are supplied by the ulnar and median nerve, they can do, patient can do actively, yes. So with this splint, patient can actively do flexion of the fingers and the thumb, okay. But due to the elastic action of the rubber band, yes, generally we use rubber band or even the glove rings also, yes. So due to the elastic action, passively there will be extension. So this splint is allowing movements at the fingers. So that's why it's called as a dynamic cock-up splint. But it won't allow any movement at the wrist joints. That's why it's called as a cock-up splint. So it will be useful for patients with wrist drop. Also, it will be preventing the tendon degeneration, okay, which means even though they are mobilized in the neutral position, there are possibility that because of immobilization, disuse atrophy, yes, so because of that some tendon injury may happen. So to prevent that, the patient can actively do flexion and passively the extension will be taken care by this dynamic cock-up splint. So here you can see the difference side by side. So this is dynamic, this is static cock-up splint. So coming to the next one, knuckle bender splint. As the name suggests, it is bending the knuckles. So what is the problem with the knuckles? Yes, so it is used for claw hand. So either complete claw hand or ulnar or medial side partial or median nerve injury partial claw hand. So what is meant by claw hand? We have already discussed this in peripheral nerve injury, yes. So what is meant by claw hand? Claw hand means, yes, there is hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint, okay. So this is the classical look of a complete claw hand. So what is the reason for the claw hand? Okay, we all know that it is the complete claw hand, ulnar nerve and median nerve injury. So what is the main pathology? So the nerve supply to the lumbricals are affected. So how to remember the nerve supply of lumbricals? See, or what is the function of lumbricals? Better question will be, see, what is the shape of this letter? It is L. So L for lumbricals. So what is this lumbricals doing? They are doing extension of the interphalangeal joint, extension of the interphalangeal joint and flexion of the metacarpophalangeal joint. So since the lumbricals are affected in an ulnar nerve as well as a median nerve injury, so because of the lack of lumbricals, the metacarpophalangeal joint is going for this thing, hyperextension, because the flexors are paralyzed because of lumbricals. Yes, because the lumbricals didn't act. So the flex extensors are overacting at the metacarpophalangeal joint, and here since the extension which is done by lumbricals is absent, the long flexors of the fingers are overacting. So that's why the claw hand happens. So the main purpose of the knuckle bender splint is it will be bending the knuckles. On the other hand, it will be maintaining the extension of the finger, this thing, interphalangeal joint, which means the fingers. Yes. So coming to the next one, Kapiner splint are also called as finger bender splint. So what is the purpose? Their main purpose is for the keeping the proximal interphalangeal joint. Yes, proximal interphalangeal joint in extension. Okay, so whenever there is a flexion contracture of the proximal interphalangeal joint, to maintain it in extension, this Kapiner splint will be useful. Then next use, whenever there is a dislocation in the proximal interphalangeal joint or subluxation, so to maintain it in neutral position, for the purpose Kapiner splint can be used. Third thing, whenever there is a collateral ligament injury in the hand, collateral ligament injury, so for keeping in the neutral position, Kapiner splint will be used. And the fourth purpose, we all know in rheumatoid arthritis, Bottomier's deformity. So this is the Bottomier's deformity of the hand that is common with rheumatoid arthritis. To maintain the proximal interphalangeal joint in extension, this Kapiner splint can be applied. So coming to the next one, hinged knee brace. So similar to the hinged elbow brace, here there also hinges will be present. Yes, so these hinges will lock the certain degree of flexion at the knee joint. Okay, so assume that patient is having an osteoarthritis and patient can do flexion only up to 90 degree or 100 degree. Yes, so after that patient is having severe pain. Yes, so because of severe pain, what the patient will do, they won't do mobilization. So this is a very problematic thing, because in a synovial joint, whenever a patient because of pain, if they don't mobilize, so what will happen, the synovial fluid, because we all know a fact that our cartilage is aneural. Yes, our cartilage doesn't have blood supply or there is no nerve supply. Yes, but how come they will get the nutrients? It is because of the synovial fluid. Yes, once the synovial fluid flushes out, it will be bringing the required nutrients for the cartilage. So if the this thing synovial joint is in complete rest, yes, or if it is not doing adequate mobilization, so what will happen? These synoviocytes won't produce the synovial fluid. So there will be decrease in synovial fluid. So automatically there will be exaggerated cartilage degeneration when a patient with the early osteoarthritis is taking more amount of immobilization. So that's why even when there is arthritis, near like osteoarthritis, they should do mobilization with the supportive bracing. So for those patients, hinged knee brace or any kind of knee brace will be helpful. Yes, and for other cases like an ACL ligament injury, psychological basis, assume that a sports person is undergoing an ACL reconstruction. Yes, due to post-traumatic stress, what will happen whenever a patient is going and doing his regular activities like sports activities, he will have some minor inhibition. Yes, for certain period he will feel that trauma in his mind. So that time for a supportive therapy, we have to give him this brace. Like, see man, actually this works very much in the clinical setup. Yes, but what we have to tell them that, see, this is a very supportive brace. Yes, so if you use this brace, there is less likely, there is less chance that in future you will be having a ligament injury. So that's why in sports persons regularly who are more prone for the knee injury, like football players, even for a prophylactic use, we will advise to use a knee RO, this thing, hinged knee brace or a simple knee brace. Yes. So the next one, ankle foot arthrosis, also called as AFO. So this you might have seen routinely. Yes. So what is the purpose? This is given to maintain the ankle joint in neutral position. Yes, neutral position, which is dorsiflexion, 0 to 5 degree of dorsiflexion. Yes. So what are the common indications? Yes, patients with foot drop. So foot drop causes common peroneal nerve injury or directly a sciatic nerve injury. Yes, then patients with a paraplegia due to spinal injury, patients with paraplegia. So routinely we will give AFO, ankle foot arthrosis. Then third one, patient who are unconscious or comatose, or patients with stroke. So in the affected side, we will be giving an AFO, because once the patients doesn't feel, they don't have sensation, so to better to protect the ligaments in the foot and to maintain the foot in neutral position. So what will happen if the patient on long term they are in this thing plantar flexion? What will happen? Our tendo Achilles. Yes, so assume that this is a foot. Obviously this is not a foot. Yes, so assume that this is the foot. So if the patient is keeping in the plantar flexion for a long term, what happened? The tendo Achilles go for contracture. So they will require one more surgical procedure to release the tendo Achilles. So to prevent that, yes, so it will be better if we give a ankle foot arthrosis. So the next one, patellar tendon bearing caliper. So previously itself I have discussed regarding the functional bracing regarding PTB caliber. So what is the main purpose of this? So in PTB caliber, the main function is, yes, the main motto of using PTB caliber is, I want to immobilize the ankle joint as well as the distal 1/3 part of the tibia. Yes, Okay, so in any cases, assume that distal 1/3 fracture tibia, which is uniting the fracture with an implant in situ, it is uniting to prevent. So just to protect the distal part of the tibia, I have to immobilize the whole limb, so which is not required. Yes, so I want the patient to mobile, which means the knee joint to be mobile. Yes, on the other hand, I want to immobilize the ankle joint. So that time I will give a PTB caliber, which will be protecting the weight bearing at the ankle joint. On the other hand, see, you can see clearly here there is some curvature like this. Yes, so this curvature is to hold or it to accommodate the lower pole of the patella. So this will be providing the required torque for the extension. Yes. Okay, so this is called as a PTB caliber or PTB brace. So what are the indications? As I already mentioned, any distal fractures after fixation, if you want to give protective weight bearing, yes, you don't want to risk, yes, so that time we can give this PTB caliber. Then pilon fracture, which means a intra-articular fracture of the ankle joint or the distal part of the tibia. Yes, then any ankle arthrodesis or any ankle related procedure, bony procedure is done, then that time also we can give patellar tendon bearing caliper. Then as a functional bracing, as I already mentioned previously, assume that there is a shaft fracture of tibia with a implant or nail in situ, particularly nail in situ, and there is a non-union at the fracture site. Okay, so there is a non-union at the fracture site. So I want to induce union with the help of the PTB caliber. What I will do? I will do dynamization of the nailing. Dynamize the nail. Yes, I will. Actually, I have already explained this in the implants topic. I will do dynamization. Then I will ask the patient to do weight bearing with the support of the PTB caliper. So for the functional purpose also, this PTB caliber can be used.